So, shall I call the next speaker? The next speaker is Dr. Raghav Preetam, and he's going to be talking on sailing against tides, deviating from the Lyra protocol.
Good afternoon, everyone. At the outset, I'd like to thank APO and AIOS for giving me this opportunity. Today, my topic is on sailing against the tides, deviating from the Lyra protocol. I have no financial interest. Why do we need such an approach? Because the Lyra protocol, ALCAN, gives you FDA-approved guidelines within which you can do the procedure, beyond which they suggest not to do the procedure. To overcome this problem, we started doing topo-modified refraction, where we try to correct the entire topolizer astigmatism. However, it's not taking into consideration the posterior corneal astigmatism, as a result of which we saw some surprises and axis flip which kept happening. The more accurate way of doing it is using the Foresight's analytical engine, but again it's an additional software you need to have, and when the disparity of astigmatism is greater than 1.25 diopters, again the results have not been that great. So just to try to understand our approach here, just look at an example of a 21-year-old girl with a refractive error of -4 sphere with -1.25 cylinder. Here the important point to take is the plus 0.3 posterior corneal astigmatism. We did a good topolizer scan. You can see the 3 ticks in the center. And now we got the measured astigmatism as -1.91. So going to the planning station, first we have to optimize for astigmatism, where we take the anterior corneal astigmatism from the topolizer, which is 1.91, subtract it from the posterior corneal astigmatism as acquired from Pentacam. So we have an effective new astigmatism, and the topolizer axis is always taken in all the cases. Then we try to adjust for the spherical equivalent. Because now the cylinder has changed, we have to optimize it with the sphere. So this is the modified refraction which we get at the end of step 1. The second step is where we look at the high order aberrations, and you can see that most of the times we see a trefoil or coma present in the periphery of the cornea. So it has to be neutralized when we are doing topo guided corrections. So the amount of corneal ablation it takes is a 5 diopters minus 2 microns, which will come somewhere around 3 microns, which is need to neutralize the peripheral trefoil. So again, optimizing for the high order aberration, 3.3 microns adds a 0.2 diopters of induced myopia on the central cornea. So we again try to neutralize this in the final correction, and the final correction comes to somewhere around 4 diopters with -1.6 cylinder. This is what we did for this patient. And at the end of 3 months, the vision is 6/5. More importantly, if you look at the axial or sagittal curvature, you can see that the astigmatism pattern looks more or less same pre and post operatively. To come to our outcomes, we had 378 eyes with mean age of 24.7, male to female ratio 170 to 207. When we come to outcomes in terms of sphere, cylinder, and mean spherical equivalent, all have improved both statistically and clinically. In terms of sheer visual acuity on Lagmar chart, we can see that the vision has improved to 0.03 end of 6 months. And in terms of Snellen chart, 97.55% of the patients had vision 20/20 or better. 30% of these cases improved to vision to 20/16 as well. Efficacy index was 1.5 and safety index of 0.5. We had 2 cases of haze, one resolved with steroids, one needed PTK. Interestingly, we also did a small subgroup analysis where we had 79 eyes which were deviating from the ALCAN guidelines, and we were successfully able to do topo guided corrections in them. And we compared this cohort to the entire study, and the results were comparable, and there was no statistical difference between this group when compared to the total group. We also compared our results to the existing literature, and the uncorrected distance visual acuity of around 20/20 or better was seen in 85% of cases or 90% of cases in most of the studies, and we had it close to 97%. And the spherical equivalent was also more or less similar to the existing literature. Some limitations of our study is a small sample size with very specific characteristics. We assume that the posterior corneal astigmatism is a numerical value instead of a vector. We did not account for lenticular astigmatism. It is a shorter follow-up period, still 1 year, and it has limited external validation. To conclude, we are suggesting an objective and non-machine dependent approach to topo-guided corrections. It addresses the axis flip and posterior corneal astigmatism related queries from the previous approaches. Outcomes are comparable clinically, and the axial curvatures actually try to mirror the preoperative maps, the implications of which are not known at this point of time. Thank you.
Nice presentation. Do you look at the anterior float of the planned ablation to the what is the present defect on the individual's cornea, and do you see whether these two are on alignment in your protocol?
Sorry, ma'am, I didn't get the question.
Uh, See, like in a topo guided treatment, what we do is we look on the anterior float map, the kind of ablation pattern which is going to happen to the original defect which is there, and we see whether the two are getting aligned.
Yes, ma'am,
I mean,
we
because
do that. Yes, ma'am. Yeah.
Because sometimes by correcting for posterior corneal astigmatism, internal astigmatism, you should not end up over-correcting. These are eyes which have come for refractive surgery, no? So
Yes.
you should not induce some kind of a myopic or a hyperopic shift.
Absolutely,
So-
ma'am. So we did look into the map while we are correcting it. Like when you said when you are doing the planning, just before going ahead with the surgery, we try to get the circle of least diffusion to the center. And in all our cases, it was also being done, and the center of least diffusion was in the center. Where it was pulled, even in the image I showed you, the center was shifted towards the trefoil. We brought it back to the center, and it was round in the center in most of our cases.
Do you think it's more theoretical than practical? All these, whether it is the other,
Ma'am,
or the other
so
protocol.
at this point of time, we don't have so many ways to assess the exact quality of how the patient reads. Probably the vision is still 6/6 in most of the patients, but the difference might be the contrast, which might be better in the evenings, or dim light awareness, or the amount of contrast sensitivity they have, or the amount of glare they are facing. Probably those are much finer but difficult things to assess in these patients.
Thank you.